and she has just had talked to us a little bit about the opportunity to share a little bit of information about Sanford and some of the EMS programs. I'm going to just breeze through this quickly, go over some of the EMS programs that we offer, and then we'll get into the endocrine emergencies component. So just confirming that you can see my screen.
Yes, we can, Travis.
Okay.
Thank you.
Thanks. So first and foremost is just a huge shout out and thank you. Dang you, COVID-19. You've raised havoc on our year and kind of have thrown havoc into our lives. And so a huge shout out to all of the EMS care providers across the state and honestly within the region and across the United States for everything that you're doing. This has been a horrible year, I think, for healthcare. We've been thrown a lot of curveballs, and EMS has really come to the spotlight of being the heroes on a day-to-day basis. And so thank you for everything that you're doing. I think EMS does not get recognition on a day-by-day basis enough. And so EMS providers really are the heroes in the communities that take care of the sick and injured. They drop what they're doing on a daily basis when the tones come across. You make the sacrifice for your personal time and you're giving that up when you're covering calls. And so more importantly is you're that out of hospital partner that we rely upon as a healthcare organization to help manage the sick and injured outside of the hospital until they arrive at the hospital here in Sioux Falls. And so EMS is an integral component of the healthcare system. So the question I ask is just how can we at Sanford, the Center for Pre-Hospital Care, EMS Outreach, how can we help you with your educational needs? And so just to highlight a couple of the programs that we have at the hospital. First and foremost, we have our monthly live EMS education program. This is a live presentation. Every Monday evening, we have 2-hour live presentation that's conducted through GoToMeeting. That meets all of the NCCR state requirements for recertification. We offer 10 sessions, 10 different topics per year. It's 2 hours each Monday evening that we do the televised presentations. We have an online portal that the students have access to for all of the recorded sessions. We are CAPC approved, also have approval from the state South Dakota, state of Minnesota for these hours, and also the South Dakota Board of Medicine for ALS hours as well. It's a convenient way to obtain your continuing education hours from the comfort of your home. We have a number of EMS agencies that participate in the sessions as a group. We have a number of individuals that participate at home individually. And then we actually have some international partners over in Guam that participate on a monthly basis as well. And so this gives you the opportunity, especially during COVID back in April, May, and June, we offered this program for free. We had about 400 participants in the free program that took advantage of it and were awarded CAPC accredited hours for those sessions. The session, the program itself is about $100 per year. That includes the 10 months of live televised education. It also allows access to the 70 plus hours of recorded information and presentations that we have embedded in the online portal as well. So if you're interested, send us an email, emsservices at sanfordhealth.org for more information. Our EMT course, we do an EMT class every fall and spring. We'll be starting our spring course coming up here in January. We're in the process of our fall course. The EMT course is $850. It includes the textbook, includes National Registry Psychomotor Skills Testing, American Heart Association BLS certification. All of the lectures are live, televised Tuesday and Thursday evenings. We record all lectures for the students to have access to if they miss a session or to re-listen to another session that they wanted more clarification on. We also have our high school HOSA EMS EMT programs that we offer through a number of high schools across the state. The students actually get high school credit for attending these courses as well as college credit for attending the class as well. And so If you have individuals in your community and individuals with your agency that are interested in attending the EMT class, or high school seniors that are interested in taking the EMT class, again, feel free to reach out to us and we can provide them more information on the EMT class that we provide. We also have our paramedic program that we have a collegiate partner with. Students receive 46 college credits. They're, if available and eligible, they can get federally backed financial aid to attend paramedic school. The program itself is 5 semesters in length. There's clinical rotations that are at the hospital here in Sioux Falls, as well as availability for attending clinicals at some of our outlying network facilities. We do skills labs here in Sioux Falls 1 Saturday per month for the students to practice those advanced skills. Their clinical rotations are either in the hospital or with an EMS agency, and we have other outside partners that the students are rotating through as well. We do have a CAHEP accreditation for the program, and I think we're on cohort number 6 coming up in January. So if you do have someone in your community or someone in your agency that's interested in going to paramedic school, again, reach out to us at emsservices@sanfordhealth.org, and we can provide more information in regards to the paramedic program. Our annual EMS refresher is coming up in January. It's January 6th, 7th, and 8th. At this time, tentatively, we're still planning on hosting it and potentially offering it as an in-person event. It's 25 plus hours of continuing education that meets the National Registry's NCCR requirements, as well as the state of South Dakota's recertification requirements for EMS providers. It's a 3-day refresher from 8 in the morning until 5 in the afternoon. Generally speaking, it's a physician-led or subject matter-led content lectures that are provided for the participants. With the course fee of $150, participants get the 3-day event, as well as access to the online refresher program that I mentioned earlier. It's a $50 savings for the combination of both of them. So for those that are nationally registered as an EMT and you need 40 hours of continuing ed, you're able to get those hours through the refresher program, as well as you're getting free access to the monthly education program where you can acquire the remaining hours. For the ALS providers, this covers your content for your advanced EMT or paramedic renewal, as well as having access to the monthly education program will provide you the remaining hours, both with live content and or recorded content if necessary. And if you have questions, again, feel free to reach out to emsservices@sanfordhealth.org. Sanford, as well as Avera and Monument Health or Rapid City Regional, have been SIMSD partners with the state of South Dakota and the EMS office, Department of Health, Rural Health Office since 2009. And we continue to provide those outreach simulation opportunities, not only for hospitals, but EMS agencies. We do simulation-based activities for adult, pediatric, infant, and OB scenarios. They're all intended to be interactive scenarios with the participants. We are taking COVID-19 precautions when we're doing and conducting the sessions. Education credit is available for those individuals that are participating. Generally for EMS, we do the sessions as a 6 o'clock to 10 o'clock session in the evening, providing you 4 hours of continuing education, hands-on application within the scenarios. And if you're interested, again, for any information, more information on these opportunities, you can contact us at emsservices@sanfordhealth.org. We provide both the American Heart Association and NAEMT courses through our office. Generally speaking, the ALS courses such as PALS and ACLS for the paramedics or advanced EMTs, BLS certification, obviously, for all healthcare providers. And then for those individuals that are taking care of neonates or in high-risk areas, we also provide the neonatal resuscitation program, the NRP program, through the American Academy of Pediatrics. Under the NAEMT, we provide the PhD.
Travis, we lost your voice for just a couple of minutes here.
under the NAEMT, we provide the PHTLS course, the AMLS course, and then also the tactical courses for TCCC and TECC. PHTLS and I think AMLS have been a fairly standard course offering in the state for a number of years. PHTLS obviously a little bit more prevalent than AMLS, but I think AMLS provides a phenomenal opportunity for individuals to gain more information on their medical skills and assessment skills, along with differential diagnosis for medical conditions. We also offer a clinical skills conference periodically over the course of the past couple years. I think we've done 2 or 3. And this provides an 8-hour day for individuals to come in small groups and participate in 8 individual sessions during the 8-hour day. The stations include assessment skills. You can work on mechanical CPR's Lucas device, airway skills, triage, EKG acquisition and transmission skills, use of a tourniquet, OB skills, or any of the National Registry state skills that are required for EMS recertification. And if you're interested in participating in this, we kind of do it based upon requests as they come in. We have a request to do one of these in 2021 as an 8-hour event, and looking at potentially doing it sometime in the spring. We would end up taking about 50 participants in this particular event, splitting them out into the 8 different stations. You get an hour in each station as you're going through the 8-hour day. Specialty courses. We actually had an advanced burn life support course scheduled for this summer, May of 2020. Obviously, because of COVID, we ended up having to postpone that class. We'll look at offering that advanced burn life support course again in 2021 in the spring in partnership with Regions Hospital up in Minneapolis, St. Paul. They'll be coming out for an 8-hour day to do the ABLS class. It is actually a really good course. Cost on it, I think, is $75, and it's a great opportunity to gain some more information in regards to burn management and burn care. And then we'll be offering in the fall of 2021, we'll be offering a critical care review course for any individual that has the FPC or critical care ground certification, also for any of the nurses that have critical care certification. That'll be in the fall of 2021, and that's in partnership with FlightBridge ED. That will be coming up. And then last, we also work closely with AirMed, and AirMed themselves offers a variety of educational opportunities, whether it's safety training or landing zone training. They have online opportunities on the sanfordhealth.org website, and then they also provide memberships for transport memberships for individuals in the outlying communities if there's an interest. And so we certainly can be a gateway if you have interest. I've received emails from individuals in the past or calls where their departments are looking for safety training or landing zone training for their EMS service or their fire department and law enforcement in their communities. And so we can get you connected to the right individuals to get those sessions scheduled for you. And then just as far as trying to contact us, EMS services at sanfordhealth.org is our email address. You can certainly give us a call at the telephone number listed here on the screen. And then also I would encourage you to follow our Facebook page, Sanford Academic Affairs, EMS Outreach. And we post all of the sessions and classes that we're doing with the outlying communities, hospitals, EMS agencies, and then any of the upcoming education that we'll be offering. We post that information on the Facebook page as well. So again, just a little as a sponsor of the 2020 conference for the South Dakota EMS Association, they graciously gave us the opportunity to provide a little bit of information about the outreach education that we provide. I know there's a number of speakers this year that are being sponsored by Sanford as well, and so I certainly encourage you to participate in their venues as they're taking place. So any questions at all?
We haven't had any come in through the chat specifically for Sanford. The only question we have had has to do with the 24-hour refreshers in the area. And you have indicated that you've got some training. And for those that are in other parts of the state, be watching your EMS webpage, the Wild Apricot, where you logged in. As we get more information, we'll be posting additional trainings there, along with what Sanford has posted also.
Thank you. I'm gonna switch screens here one second. Amy reached out and asked if I'd provide something on endocrine and metabolic emergencies. And so is kind of looking at this topic, kind of taking consideration as far as EMS providers, what type of endocrine events do we typically encounter in the pre-hospital or out of hospital arena? And so EMS has the ability to make a huge impact on these patients that have these endocrine emergencies. In many cases, there's a multitude of endocrine and metabolic emergencies that can occur, but it's the use of your assessment skills and the application and implementation of treatment that can provide the life-saving treatment in certain cases that is a matter of life and death for these patients. So, so we'll talk about the common types of endocrine or metabolic emergencies that are typically seen in the out-of-hospital environment by EMS. I have nothing to disclose for conflict of interest. Objective-wise, I really want to focus on the assessment of the patient with an endocrine or metabolic emergency, using your assessment skills, doing a differential diagnosis, doing a differential assessment of this patient that you're encountering, and then considering how you can intervene and help manage that patient. We're going to specifically focus on diabetic emergencies because I think that's one of the most common types of endocrine or metabolic emergencies that you're going to encounter. There's a couple other endocrine metabolic events that I'll talk about, and then just the pre-hospital management of the diabetic patient in the out-of-hospital environment. We'll talk about that as well. So when we look at endocrine and metabolic emergencies, there's a wide variety of conditions. It's not as simplistic as trauma, and in some cases, it's probably not as simplistic as what you see with cardiac and respiratory events. And so these are hormonal events from endocrine, exocrine types of events that are occurring within the body through different organs and different organ systems, and impacting how these organs are functioning or malfunctioning, and either negatively, and generally speaking, when we're involved from an EMS perspective, they're negatively impacting the patient's condition. The other thing that I want to focus on is the electrolyte levels that are associated to some of these events. Now, the unfortunate thing is in the out-of-hospital environment, we don't generally have lab testing equipment that can assist us in the diagnoses of these conditions. However, patients that have an underlying history of diabetes and are known diabetics sometimes will have glucometers that will aid you in the diagnosis of what these particular events might be. And so again, utilization of your assessment skills, whether it's through dispatch information or the information you're gathering on scene, or your assessment skills once you arrive on scene, is to help manage what might be happening with this patient, and then making that differential identification as far as what the underlying problem might be. The other thing is these endocrine events can actually impact multiple organ systems. And as they're impacting multiple organ systems, you can sometimes end up with multi-organ system failure as well. So when we look at the physiology and pathophysiology of these endocrine events, they can actually be very confusing and very complex to try to figure out. And so again, we don't have the liberty or the luxury of having lab diagnostic equipment in the out-of-hospital environment, which the hospitals have. And generally it takes, hours for a physician to figure out these underlying events. The other thing too is, as I mentioned before, is they can present as a very life-threatening event with signs and symptoms that can be very apparent or very obscure, and if left untreated, can cause death for the patient. And so in some cases, a very timely treatment plan needs to be implemented so that the patient doesn't suffer any ill effects from the condition. So we talked a little bit about the endocrine organs, uh, not only the endocrine organs, but we also look at some of the different organs themselves and the organ systems that have hormonal impact. And so we see these organs throughout the body, whether it's the thalamus or the adrenal glands, or it's a pancreas, reproductive organs such as the testes or the ovaries. We look at the hypothalamus, we look at the thyroid gland. So we have a multitude of organs that we can potentially deal with that impact what happens during these medical emergencies. So the thing that we want to be able to do is look at, is this a medical event or is this a traumatically induced event? And so there are times that the question always is, which came first, the chicken or the egg? And so you have to look at the trauma patient and interpret whether this traumatic event was caused because of a medical condition or a medical emergency, or we look at the trauma event and inquire through assessment, did that trauma injury cause or induce injury to some of these endocrine glands, and then cause further impact, negative impact on the patient. So like I said, generally diabetes is one of the most common types of events that we will see in an out-of-hospital environment. Hypoglycemia, generally one of the most common medical emergencies outside of cardiac and respiratory events. We are either going to encounter those patients that are hypoglycemic, that have very low blood sugars, or we're going to encounter those patients that have hyperglycemia or high sugars. We can also get into excessively high sugars, such as HHNC, and that has a multitude of other physiological effects and impacts on the patient as how they're clinically going to do. The important thing with diabetes is that those patients that are hypoglycemic need to be identified and managed emergently and quickly, or their hypoglycemia can lead to death, cardiac arrest. For those patients that have hyperglycemia, I think those encounters occur on occasion in the out-of-hospital environment. But the difference between these two is that those patients with a very high glucose level are managed clinically over multiple days in the hospital, and most commonly in the critical care units, because of the complexity and complications that are associated with extremely high blood sugars. Diabetes is one of those medical conditions that has patients that can be diagnosed or undiagnosed. Diabetes itself is a type 1 or type 2 diabetic event. And so we typically look at those patients that are either taking insulin or maybe they might be a diet-controlled diabetic. Patients that might be taking subcutaneous insulin as they're measuring their glucose levels throughout the day, or patients that maybe have an insulin pump that automatically measures and it kind of adjusts their insulin dose, or maybe they give them a basal rate of insulin throughout the day. And so the type of diabetic emergencies that you're going to encounter, again, most commonly, you're going to be the hypoglycemic events, but we can also see these hyperglycemic events that present as an altered mental status, or patients that maybe might have a septic event, infectious event that's going on that's complicating their underlying diabetic history. The other thing I think that's important to look at these endocrine or metabolic events, emergencies, is also electrolyte disturbances. And so we have part of your plasma in your blood is the transport mechanism for these electrolytes. And so we look at some of the electrolytes that are really key factors for the health and well-being of an individual. And so, most commonly we think of sodium, potassium, calcium is another one. And so sodium and potassium have an unbelievable effect on our neurostatus and then also our cardiovascular status. The calcium levels are managed or kind of clinically controlled through our hypothalamus and endocrine gland. And then your thyroid gland kind of controls your metabolic process, and your metabolic process is a way to kind of identify that. So when we look at these underlying disorders, again, we don't have the liberty to have this lab testing equipment to say, hey, this patient is hyponatremic and has a low sodium level, or they're hyperkalemic and have a high potassium level. But what we do have the ability to do is look at the history and the assessment information that's being presented to us. What's happened to this patient over the past couple days, what's happened to this patient, over the past 24 hours, and then take that information and apply it to what we know about electrolyte deficiencies or electrolyte disturbances, as well as endocrine events as well. And so, as an example, a patient that might be hyperkalemic, an individual that has a very high potassium, this is commonly seen in those patients that are on hemodialysis. And so you would take a patient that's on hemodialysis and they're getting dialyzed maybe 3 times a week, Monday, Wednesday, and Fridays. And they have over the weekend, they have off, and then they come back in and get dialyzed on a Monday. And so it's not uncommon to find that patients maybe become ill or sick and don't keep on schedule like they should, and they miss one of their dialysis runs. And so maybe they get dialyzed this week on Monday, Wednesday, and Friday. Over the weekend, they become sick, and by Monday, they're not feeling well enough where they can travel to the hospital to get dialysis, and so they miss their Monday dialysis run. And so you might, as an EMS provider, get contacted on Wednesday or maybe even Tuesday because of a patient with an altered mental status and excessive weight gain, respiratory, cardiovascular compromise. And so these hyperkalemic patients, based upon their underlying history, can run into very complex life-threatening events with these high potassium levels. And so what we do as an EMS provider, how we manage these patients becomes important to what their outcome is. Sometimes, in a dialysis patient, a hyperkalemic patient, based upon your skill level, there are things that we can or maybe can't do in the out-of-hospital environment to help manage this patient. But getting the patient to the hospital where they will be medically managed over several days is the key factor here. Hyponatremia generally is a common disorder we see with maybe like water intoxication, where my daughter actually had this a couple years ago. She ran a marathon, her first marathon, and I provided her the medical advice to stay hydrated, make sure you're drinking water throughout the week. You're going to be sore because of potassium spill and stuff like that, and you're going to get cramping and stuff from running a marathon. And she literally drank gallons of water over the course of the week and ended up hyponatremic with an extremely low sodium level. And again, not something that we can check in the out-of-hospital environment, but we look at the clinical presentation of patients with weight gain and edema and altered mental status, and poor peripheral perfusion, discoloration of the skin. Those are things that we look at from a diagnostics perspective, and look at to say, is this a patient that could have, based upon their background and history, the events that have happened over the past couple days, is this somebody that could be hyponatremic? Thyroid disorders, you have your thyroid gland, which again controls your thyroid hormones. You also have your parathyroid glands that control calcium production. We see patients that have surgically had their thyroid gland removed, or maybe their parathyroids, a portion of their parathyroids have been removed. So they may have some medical emergencies associated, to those disorders. With surgical removal, it's generally more acutely at the time of the surgical event versus down the road. But there are those individuals that certainly can have hypo or hyperthyroidism, thyroid toxemia. Generally causes a lot of cardiovascular, cardiac arrhythmias and dysrhythmias, tachycardia events. And so somebody that might present with a cardiac underlying event with tachycardia, shortness of breath, and chest pain might actually be a thyroid toxic patient that's presenting. So again, it's not necessarily just the cardiac events, it's potentially an endocrine disorder that's underlying that. We also look at renal issues with the adrenal glands. This is sometimes a common hormonal organ, endocrine organ that's injured during traumatic events, injuries to the flank area, motor vehicle crashes, football events, any blunt injury to the posterior section of the back, where they can have adrenal disorders. Some medications can also cause complications either through electrolyte, thyroid, or adrenal disorders. If somebody's taking a diuretic, for example, we always look at if they're a potassium sparing or non-sparing type of medication where they're diuresing or peeing out a lot of fluid. And so that's one of the things we look at. And then we look at, again, the adrenal glands have a impact on our cardiovascular system, our blood pressure. And so again, a patient that presents simplistically as a hypertensive patient, we really need to look at it as just to identify what's the underlying cause of that hypertensive event. As I mentioned earlier, medications can induce some of these events from a hematological standpoint, a blood disorder perspective. We use the blood to transport some of these electrolytes around our body. These are organs that are impacted by the perfusion of blood. And so we want to take into consideration underlying blood disorders as well. As I mentioned earlier, they can have multi-system organ impact if there's problems. And then also for males and females, we look at the reproductive disorders that can occur. And in the out-of-hospital environment, reproductively, we probably encounter more female reproductive issues, whether it's a ruptured ovarian cyst, or maybe it's ruptured ovaries, maybe it's a OB-GYN complication, out-of-hospital delivery. So there are those conditions that we take into account as well. So when you see the signs and symptoms, the key factor here is what I want you to be able to look at is what are the signs and symptoms that the patient's presenting with. And so I always throw out the question for individuals as we're going through assessment skills is what's, you have a patient that presents with chest pain, what's the underlying cause of this patient having chest pain? And so one of the things that we look at is, is this a 18-year-old individual that's having chest pain? Is this a 30-year-old individual having chest pain, or is this an 80-year-old individual that's having chest pain? Because the underlying cause of why this patient is having discomfort is going to be dependent upon what the underlying causation is. And so just because they're having chest pain doesn't automatically mean that it's a cardiovascular event. It could be a symptomology associated to an endocrine emergency that is impacting the cardiovascular system, causing tachycardia or maybe even shortness of breath. So we want to be able to identify that if at all possible. The other thing too that you want to be able to do is evaluate the patient's medical history. And so we use our sample history for that. So we look at the signs and symptoms, we look at their allergies, we look at what medications they are taking, we look at what their past medical history is for previous conditions. And so do they have a history of diabetic emergencies? Do they have a history of thyroid disorder? Do they have a history of GYN complications? So we look at what that past medical history is, the medications they might be taking. Now, in today's world, the PDR, your medication reference books, they're thousands of pages thick. And so, for the individual that's not maybe a pharmacist and not familiar with medications, really the bigger question I always emphasize people to ask is, why are you taking these medications? You're going to get patients that are that have a polypharmacy, and so they're on multiple medications. So you might come across an individual. I was visiting with a friend the other day, and they said, "My grandfather is 95 and he doesn't take any medications." And I said, in today's day and age, that's kind of unheard of. But then you can also see a 25-year-old patient, in the out of hospital environment, and they're on 25, 35 different types of medications. And so those patients that are have a polypharmacy or multiple medications, we look at those individuals and look at why they're taking the medications. The other thing that's important to look at when you're doing that assessment of medications is, are they taking the same medication in multiple doses? And so do they have multiple providers or prescribers of the medications as well? And so the reason of why they're taking the medication might help you figure out the symptomology of what the underlying event might be. The other thing we look at with differential diagnosis is the rule-ins or the rule-outs. Those signs and symptoms. If somebody tells you you have a patient that's got crushing chest pain that radiates down into the arm, that goes into the jaw, into the neck, automatically we've been taught, by textbook to think, oh, that's a cardiac event. That's a patient having chest pain, a cardiovascular emergency, or a patient that has been immobile for a period of time and moves from a stationary position, maybe from a traveler in an airplane, for example, and suddenly becomes acutely short of breath with chest pain. And we think of a pulmonary embolism in that particular case. So we look at some of these rule in, rules out, these obvious signs and symptoms that are associated with these textbook diagnostic descriptions. But as you're going through these underlying causes of why is this patient having the symptomology, we need to be able to figure or look at, is this a likely cause of why this patient is ill or presenting to us in the out of hospital EMS environment. The other thing too that's important is a patient that's having chest pain because of a cardiac event might be differently evaluated and treated than a patient that's having referred chest pain because of a gallbladder event, or a patient that's having chest pain because of a thyroid disorder. And so the underlying cause and what needs to be treated needs to be the underlying condition. And so if we treated a patient that's having chest pain, that's having an endocrine thyroid disorder or a thyroid toxicity, providing that patient with nitroglycerin isn't necessarily the therapeutic treatment for management for that patient. What we need to be able to do is to slow that patient's heart rate down, because typically that thyroid toxemia causes tachycardia. And so we want to be able to slow the heart rate down for that patient. Generally, that's going to be done at the hospital, not necessarily in the out of hospital environment. And once that thyroid level becomes normalized in the patient's bloodstream, then the symptomology generally will go away as well. But we do have to treat the symptoms that they're encountering at the time. So if they're short of breath, we treat them with oxygen. If they're having chest pain, we really have to look at what's the underlying cause of what's causing that chest pain. Our course of action for management, really hypoglycemia is that one that has to be treated on scene. It needs to be corrected. We don't have time to wait until that patient gets to the hospital because this is a patient that clearly can go into cardiac arrest because of a hypoglycemic event. The brain uses glucose as its primary source of energy, and so managing that glucose level is going to be vitally important to try to raise that level of glucose up in the patient's body to prevent any ill outcomes or adverse outcomes for the patient. So as mentioned before, diabetic emergency is probably one of the most common metabolic endocrine emergencies that you're going to come across. The signs and symptoms, whether it's a hypo or hyperglycemic event, are very textbook. So if you have that patient that is an altered mental status with cool skin, diaphoretic, and acutely came on with symptomology, we automatically kind of go to this is potentially a hypoglycemic event. If you have this patient that has been sick for a couple days, is a known diabetic, has hot, warm, dry skin, with an altered mental status, that's generally somebody we might be thinking that has a hyperglycemic event, or a patient that is advising that I'm just constantly up all night, I can't get any sleep because I'm constantly going to the bathroom and I'm urinating, I'm constantly drinking a lot of water. So we look at they're peeing a lot, they're eating a lot, and they're drinking a lot, and so they're spilling ketones, they're spilling that glucose in their urine, as the body's trying to do that to rid itself of this high level of sugar that's currently in the body. Um, that's also the hyperglycemic patient, where you might have that ketone acetone breath for the patient. And so um, again, these hyperglycemic patients are managed over multiple days in the hospital in the ICU. They're not, generally treated as an ER patient. They're admitted because these blood sugars of 800, 1200, 2000, 2500, 3000. These extremely high blood sugars are very, very delicate, cause significant complications to the patient's underlying condition. The high blood sugars can cause cardiac arrest just as easily as the hypoglycemic event. But generally, for the known diabetic that has diabetic conditions, the body is somewhat tolerant sometimes of those high sugars. I think back of a patient that we had that was hyperglycemic, had a blood sugar of 2200, and in the transport of about 35 minutes, arrested 6 times in the back of the helicopter on the way back to Sioux Falls, going into VTAC. And so that extremely high blood sugar, electrolyte imbalances were causing significant clinical instability for the patient, and very complex, with a very complex management plan to control the sugars. We talked about the hypoglycemic is the easiest one, that we kind of identify. We can provide the sugar on scene. We can improve the patient's level of consciousness. Sometimes those patients will also utilize glucagon if it's a common type of medical emergency. Sometimes the family members might have a glucose with them that they can administer to the patient, or maybe they already have tried to administer the glucose or glucagon for the patient, and have been unsuccessful, and that's why you're getting called as an EMS provider. Diabetic basics, we look at really what's going on with the pancreas. Is it or is it not producing insulin, or is it a mismatch of the body and the inability to use the insulin that's being produced by the pancreas? And so if the pancreas is producing insulin and the body's able to use it, generally speaking, your patient's not going to have diabetic complications. They might be overweight, they might have poor food selection, and they're naturally running a high glucose level under normal conditions. And that may be diagnosed or undiagnosed. Usually, the medical providers, once they identify high glucoses, they have a kind of true heart-to-heart with the patient and advise, that they need more physical activity, they need a better eating habits, and then kind of threaten with medication management for the glucose level. Sometimes the pancreas is producing insulin, but it's not functionally usable by the body. So there's an adequate amount of insulin in circulating in the body. It's just not functionally usable by the body. The other thing that we look at is the pancreas is not producing any insulin. And so then these patients generally have to use an artificial source for insulin. Excuse me. The other thing too that we look at is this a medication event? And so is this a fact that the patient's has not been taking their insulin, or is this a patient that has been taking too much insulin, or is this a patient that has encountered an insulin pump error, or they've maybe run out of insulin on their insulin pump, and so now all of a sudden this patient that doesn't have any insulin in their insulin pump has an extremely high blood sugar? Or maybe this is a patient that tried to commit suicide because of an underlying behavioral health issue, and now all of a sudden they've tried to commit suicide by taking insulin. Or maybe you have a patient that has glaucoma because of a complication, a poor eyesight because of diabetes, and they can't adequately see how much insulin they're drawing up, and so they accidentally overdose on taking too much insulin, or they're not taking enough insulin. The other thing that we look at with diabetic basics is the environmental impact. And so sometimes patients that are insulin-dependent diabetics have a mismatch of their carbohydrate intake or their activity intake based upon their medication dosing and their food intake. And so if they're extremely active, obviously they're going to be burning sugar, so they need to take in more carbohydrates, they need to take in more sugars to provide that form of energy. And maybe the insulin that they're taking or they're being prescribed is either too much or not enough for that particular event. And then occasionally we run into just insulin pump issues where they're does not match up with the type of activity that the individual is engaged in at that time. So when we do our assessment, really you can gain a lot of information just from your surroundings. So I always emphasize is that we have all kinds of thousands of dollars of tools in the back of an ambulance to help us assess the patient, but really God has given us, really 5 great senses to use as our tools in our toolbox to find out what's happening to this patient. So we can use our sense of sight, not sight, and to look at how this patient is presenting, the environment that they're living in, how they're presenting once you arrive on scene. Again, you're using your sense of smell. So if you have a patient that is hyperglycemic and you're sensing that fruity acetone odor to their breath, you might consider that they're a hyperglycemic patient. You're using your sense of touch to assess the skin condition. Is this warm, dry skin, so you're concerned about hyperglycemia, or is this cool diaphoretic skin where you're concerned about hypoglycemia? You're using your sense of hearing and sight kind of together. And so if you walk in and find the patient that's got who's unresponsive with snoring respirations, you're seeing that and how they're positioned. You're also listening for the altered mental status. You're using your sense of hearing to gather the information from either the patient or the bystanders or family members or dispatch as far as the events there. So I always kind of jokingly say you can use your 4 senses. Patients don't generally appreciate it if you start licking them. So don't use your sense of taste for your patients as you're clinically managing them. So as you're gathering information, like I talked about before, is dispatch might provide you information and give you the clues that, hey, this is a diabetic event. You might arrive on scene and bystanders are saying, yeah, I saw Bill 15 minutes ago, 20 minutes ago, just before lunch, and all of a sudden I found him unresponsive in the men's restroom, and maybe Bill went to the bathroom to take his insulin, but didn't get a chance to grab something to eat. Your prior knowledge. Sometimes you have, what people refer to as the frequent flyers, where you're getting called to this address and it's a known diabetic and it's a known hypoglycemic patient, and they generally refuse treatment or transport once you increase their sugar level. So it might be coming from prior knowledge of this patient as well. The level of consciousness, whether this is a patient that's got altered mental status or is completely unconscious or is alert and oriented, just looking at that component and that differential piece of it is this an unconscious patient with snoring respirations, with cool dry skin where you're thinking hypoglycemia, or is this a unconscious altered mental status that's got warm dry skin where with a known history of diabetes that you're thinking that this is a hyperglycemic event? As mentioned before, you want to use your sample history. You want to use your OPQRST assessment as well. We're looking at hemodynamics for your clinical stability through vital signs and reassessing those vital signs based upon clinical stability of the patient, whether it's every 5 or 15 minutes. And then the equipment in your ambulance or the equipment that you have available to you. And so you can use the cardiac monitor, you can use your pulse oximeter if you have a glucometer and you're able to do that, or maybe you're using the patient's glucometer. You're looking at the patient's glucometer to identify what the history is inside of that. You take a peek at the insulin pump at the rate that the insulin pump is on. You look at those environmental conditions and keys that provide you the information as far as what's happening with this patient. So look at their medications, look at their refrigerator for insulin. Are they taking long-acting insulin? Is it short-acting insulin? Do they have an insulin pen? Look inside of their purse. And so we can use a lot of the equipment that we have in the back of the ambulance, but again, be very attentive to your surroundings while you're on scene as well with this patient. Basic understanding, hypoglycemic events require immediate intervention. You can use the glucose, under protocol. If you do wake the patient up, maybe the family members have the glucagon where they can administer the glucagon based upon your level of training. For the paramedics, advanced EMTs, they could potentially give glucose, dextrose 50% IV. One of the things working as a paramedic that I kind of enjoyed is if you would wake up a diabetic patient on scene by giving them D50 dextrose, is that's immediately fixing the problem. You've brought that glucose level from maybe a 20 up to 120, but based upon the circumstances of what's happening with that patient, their body might consume or use that glucose very quickly, and then within the next 30 minutes, that glucose is going to immediately be consumed, and that blood sugar is going to drop again for the patient. So they need that carbohydrate intake so that the body can start managing the sugars more naturally inside of the body, other than us artificially rising the sugar. And so for the diabetic patients, I always enjoyed, if we were there on scene, is making them a meal to kind of help their underlying diabetic condition. And so whether it's something as simplistic as a peanut butter and jelly sandwich, or maybe some orange juice, or something that they can eat, milk, for example, something to try to get that blood sugar up where they can become more clinically stable, other than this boost of glucose that you've given them. The other key factor here is anything that you're giving them orally is just make sure that their altered mental status is not such where it becomes a choking hazard for the patient. And so one of the key factors is, that I always used as a kind of identifying component is if you gave a patient a glass of water with a straw for a hypoglycemic patient, are they cognitively aware enough in this hypoglycemic state to understand that they need to suck through the straw? Or do they just kind of look at you with this blank stare? If they don't have the cognitive intuition to know that they need to suck through the straw to drink that orange juice or drink that milk, anything that you give that patient by mouth is going to potentially become a choking hazard. If you have this patient that has an altered mental status and you're trying to figure out what's the underlying cause, certainly that could be a stroke patient as well. And for stroke patients, they have can have a neurological impact on their swallowing capacity. And so anything you give them by mouth as well could become a choking hazard. Clinical resources and communication based upon your scope and level of certification, based upon your services capacity and capabilities of managing these patients, advanced communication and information sent to the hospital so that the hospital is prepared for this type of a patient. The other thing too, I'm sure most of you have seen the hypoglycemic patients that become significantly combative during our hypoglycemic events can become a very unsafe situation for you. So always be very attentive to scene safety and safety of your crew, as well as safety of the patient. Make sure your patient, especially these, we've seen combative patients, stories of combative patients that have jumped out of a moving ambulance that have had an altered mental status, either whether through drugs or a hypoglycemic event. And so just make sure that scene safety for the patient and yourself are being managed appropriately. Interventions by law enforcement might be necessary, but again, we have to fix the underlying issue that's causing the combative behavior, and getting that addressed as quickly as possible. Management options en route to the hospital. Kind of this fourth bullet point is be prepared for the patient that refuses care if you do wake them up from a hypoglycemic event, because generally these known diabetics that have hypoglycemia will not want to go to the hospital. The thing for you to look at is, over a period of time, have you been to this patient's house a number of times over the past maybe week or month? where obviously their diabetic management and control of their underlying condition is insufficient, and they've had multiple events that have occurred. And so be a patient advocate and promote or encourage that patient to seek medical attention, whether with or without the ambulance. But their underlying health yeah, becomes concerning at that point. Any questions?
So Travis, we do have some questions for you.
Okay.
Okay, so for our advanced caregivers, they've been taught to give, D50 in a push. And what are your thoughts on using D50 versus using D25 or D10 for your hypoglycemic patient?
So we generally use like D10 or D20, D10 for our neonates, D25 for pediatric patients, and then D50. The important piece, or I shouldn't say the important piece, the very attentive piece for the ALS providers is dextrose is an extremely tissue toxic medication and can cause necrosis if your IV site infiltrates. So theoretically, if you had a 500 cc bag of D5W and you gave the 500 cc's of D5W, you're in essence giving an amp D50, which is just 50 cc's. The 50 cc's of D50 is obviously more concentrated. It's a smaller quantity of medication. It's easier to give over a shorter period of time versus 500 cc's of D5W is going to take a longer period of time to administer that medication. And plus you're giving them a larger quantity of volume. D10 probably will increase the sugar. D25 is more concentrated, higher glucose content, so it's going to also increase the sugar. The lower the glucose content, the slower it's going to take, or the more fluid potentially it's going to take. But the thing I would really emphasize is no matter what, whether it's D5, D10, D25, D12 and a half, D50, is just make sure you have a really good patent IV line so that you don't run into infiltration of the IV site and tissue necrosis associated with infiltration.
Okay, and you kind of alluded to it, but using the D5 or the D10 as a drip, because many of the services that are ALS have a longer transport. Your thoughts on doing a drip versus a straight feed into the IV line?
So any patient that you have that has an altered mental status, if you're in an ALS capacity, or even if you're in a BLS capacity, a patient that has an altered mental status should have a glucose checked. And then based upon what that finding is, reassessment of that glucose level over that prolonged transport time is going to be important to do. And so for the patient that, again, if you have a patient that you've given D50 to and you've brought the sugar from 20 up to 150, maybe 200, you can anticipate that sugar is going to drop abruptly over a period of time. We have to look at what's the underlying cause of why that patient's sugar is low. And so it might be, I think of a patient I had in the past that had glaucoma and couldn't see very well. And so he just kind of arbitrarily drew up insulin in the insulin syringe, and he couldn't really see how much he was drawing up, but he kind of knew that the black plunger needed to kind of be in this ballpark area of the syringe. And so maybe today he might get 5 units, maybe he might get 10 units, maybe he might get 20 units based upon his eyesight. And so if inadvertently that individual took 20 units of insulin, regular insulin, it's going to have a pretty immediate impact on that patient. And even if we give them D50, it's going to bring the sugar up right away, but that insulin is still circulating in the body. Or if they have long-acting insulin that's circulating in the body, it has a tendency to drop that sugar as well. And so giving them a little sugar consistently over a period of time in a long transport probably is not going to hurt them. For our pediatric transports, when we transport kids in the helicopter or the plane, we generally put them on a maintenance dose of D5.5 normal saline or something with dextrose in it, just because the metabolic demands of sugar for pediatric patients, because they use a lot of sugar. So our maintenance drips generally will have some type of dextrose containing solution in it. Hopefully that kind of answers the question.
It did, thanks. I've got a couple of more for you if you have time for it.
Yeah.
Awesome. So the next one we have has to do with your hyponatremia. How much water intake generally needs to occur over what time span to cause that?
I cannot honestly answer that without looking it up and giving you
Okay.
the true diagnostics. What I can reference is my daughter, after she ran the Minneapolis Marathon, and talked to her Sunday after she ran the marathon, and she was just excited. And I'm like, "How do you feel?" And she's like, "I'm just have this huge adrenaline rush. I feel great. I'm a little sore, and she'd been running and prepping for it for months, and so. But she's like, she never ran, the full marathon. She'd run, maybe 10K, at a time, or she'd run 13 miles or something, but she had never run the full marathon. And so I talked to her on Sunday, and she was, I think, just more so the adrenaline rush, and she was sore. And I just said, hey, make sure you're drinking fluids, and staying hydrated, because with all this tissue and muscle breakdown, you're going to end up with rhabdo, and you want to make sure that you're not plugging your kidneys up, and so just you want to keep your kidneys, basically keeping stuff flushed through your kidneys. And so I talked to her on Monday, and I'm like, hey, how's it going? She's like, yeah, I'm pretty sore today, but I'm doing better, And I said, just make sure you're drinking the fluids and staying on top of your fluids, so that you don't end up with, problems with rhabdo and stuff like that, especially, with the potassium release of the muscles and stuff. And talked to her on Tuesday, and she's like, yeah, she's like, I'm pretty sore today. She's like, I have been eating and drinking very well. Wednesday came along. I noticed that she had, I'm not going to say an altered mental status, but her level of communication, or her willingness to chit chat, was much less. She felt like crap. Thursday, I noted she did have somewhat altered communication capacity. Friday, she was confused, and I'm like, hey, you need to go to the hospital. And she'd still been drinking a ton of water Monday, Tuesday, Wednesday, and Thursday. And I said, hey, you need to go to the hospital on Friday. Yeah, she's like, no, I don't think so. I don't have the energy to. I don't have anybody to give me a ride. I think I'm just going to sleep it off. Couldn't get a hold of her on Saturday, and finally got a hold of her after about 15, 20 phone calls. And she's like, I'm trying to sleep. I just feel like crap. And ended up going to the hospital, and extremely low sodium level, and ended up getting treated and managed in the emergency department and in the hospital. And really big, underlying cause was, visiting with the physician. It was just the fact that she was probably drinking a gallon, 2 gallons of water a day, and not really having any nutritional value or electrolyte intake other than the water. She should have been drinking Gatorade, Powerade, or something like that, and she was just drinking the water.
Interesting story. That's good to know for that, because it went over a duration of a number of days. So that's very interesting. We
The
do
only symptom she didn't have is the last symptom was to seize, and so I think given the time, she electrolyte level wise, I think given Saturday, had it got to Saturday afternoon, she'd have probably started seizing. So she was
wow.
confused enough where she really wasn't familiar with surroundings and stuff. So
Okay. Another question that we have from the group is, can you explain allergic reaction to the insulin a person is using? How does that work? Is it possible? What do we need to watch for?
um if I would tell you something that I'm going to guess, I think just from a basic anaphylactic allergic reaction, is there's insulins are generally artificially produced, and just like any other allergic situation, you're going to develop antibodies, antigens, for that particular exposure. And so based upon the mechanics of how that insulin is produced, is the impact that it would have on the body. I personally have not seen patients that have had an allergic reaction to insulin, but as an artificially produced medication, um, it, having that allergic reaction, I would envision that possibility is there.
Wonderful. And the last question that we have for you tonight has to do with one of our members' granddaughter, who is a type 1 diabetic. She's about 10 years old, and she's been told that when her readings start to get higher, she needs to start drinking water, and the question to drink water to bring it down. And the question is the drinking water, would exercise help? You know, is drinking water as your numbers start getting higher, a good thing to be aware of?
So I think, the one thing there, kind of just looking at the question that, that as it's popping up on the screen here with that. And so generally when you do have patients that have hyperglycemic events, a basic diabetic ketoacidosis could have a patient that has a blood sugar of 300 milligrams per deciliter, 400 milligrams per deciliter. Once we get patients that have, 800, 900,000, 1500, then we start looking at, um, metabolically what type of an event is occurring here. Is this an HHNC? Is this a DKA patient? And so one of the kind of hallmark signs with patients that are hyperglycemic, a DKA patient, is that they're eating a lot, drinking a lot, and peeing a lot. And so the body's trying to pee, get rid of through the kidneys. It's trying to get rid of all this excess glucose. And so my guess is with this recommendation, and this is a guess, is that with drinking water, it's going to promote the diuresis and try to spill some of those ketones. That's not fixing the problem. Getting that sugar level under control and getting it back down is what needs to happen. Just hyperglycemia, diabetes in itself over a prolonged period of time just takes an unbelievable toll on a variety of organ systems and body parts. Diabetics end up, with vision problems, with glaucoma because of diabetes. Your kidneys become impacted because of hyperglycemic events, and so patients go into renal failure and end up requiring dialysis. End up having cardiovascular problems. And so the other thing, would be is to look at, from an acute short-term event is if the blood sugar is high. If it's just high, maybe, because I had a piece of cake and some ice cream, that it's going to probably run high from that sugar intake and that nutritional intake. Versus if it's consistently running high over a couple days, then I would look at to say, is this an infectious, event? And so sometimes, with diabetics, they unknowingly have an infection. Diabetics have neuropathy of the periphery. And so, you always hear about the diabetics that can walk around all day with a rock in their shoe but never sense it. And then at the end of the day, that rock that's been in their shoe has basically cut a hole or wore a hole in their foot. And then that wound becomes infected because of diabetic patients have a complicated immune system and they are more susceptible to infection. And so that infection then causes that blood sugar to go up high as an immune response. And so it's really getting to the underlying addressing the underlying problem of what's causing that increased sugar level.
Wonderful. Well, Travis, thank you so much for your time. And thanks for joining us for this virtual conference. I know you normally enjoy being at our in-person conferences, and hopefully in the future, we'll be able to see you again at one of the conferences. But in the meantime, thank you so much for your time and the sponsorship of Sanford for this conference. It's greatly appreciated.
Nope. Good luck. I hope everybody enjoys it. The numbers that I saw posted with registrants is awesome. I'm glad to see that people are participating, and so I wish you the best of luck and have a great conference.
Thank you so much. For the rest of you that are still on, I'm going to share my camera to help you make sure that you know where the surveys are. So let me go ahead and share. So, I don't know how the glare is going to work in here. With your, go to your guidebook, and I happen to have the listing of the schedules for all the classes. So I'm going to click on Travis's class. So you can see Travis information up top that it's a medical. If you slide down, further down on the screen, and I'm so sorry, the glare is pretty bad that you can't see it. But when you get down to the bottom, there is one that says survey. And for Travis's, it's endocrinological emergency surveys. So you'll click on that and you'll be able to take the survey for this class and get the credit for attending this class. So that's one thing we want you to be aware of. If you go down a little bit further, so if you slide down, you'll get near the bottom. And when the bottom one says conference sessions by topic, if you click on that, it has, and we've got it posted in every class, but it gives you a listing of the class, the title, the speaker, the hours, and what category it counts for. Some of them can count for 2 or 3, but we've got it broken up here so that you can see how all your 20 hours are going to be able to be matched up with the state or the national registry. And then the one other thing I would like to show you is we're coming up into our vendor fair. We'd really appreciate if you guys would go in and, click on the links to the vendors and chat with them. So to get your vendors, I'm in my daily listing. Let's see if you can see that. So I'm going to go up to what they call the hamburger, those 3 lines at the top, up by where it says schedule. There are 3 lines up there. I'm going to click on the 3 lines and I'm going to come down, and in my listing, you can see there's one for vendors. Go ahead and click on the vendors and it will bring you up a list of all the different vendors that we have. So if you click on one of them, and I just happen to click on NAEMT, you can see that there's a Zoom link right in here that you can click on. So if you want to chat with Tammy or any of the other folks at NAEMT, if Tammy's working tonight, you'll be able to do some chatting with them, ask some questions, things like that. You can do that with many of our vendors, or see their links, see their website, see the things that they have to offer, because those vendors are helping us get this education to you. So you've got about an hour to go ahead and visit with our vendors, and then we will be coming back to the general session. Let me go back and look at my schedule, see what time it's at. So we'll exit out of there and we'll go back to the hamburger to get to the schedule and see the schedule. And we see that Bill Justice with trauma vignettes will be starting 7:15 Mountain Time, 8:15 Central Time. So you have time to do your survey, go in and visit with our vendors, and take a little bit of break before we come back with Bill Justice. So we'll see you in a little over an hour and a half or there, whatever time it is. We'll talk to you later. Bye-bye.